um, the lectures, and and we're going to get those posted as well, the recordings for you folks. All right. Just a quick FYI, next week I will not be here. I'm actually going to go on vacation with my family, which I'm really excited about. So the wonderful Molly Kelly, the inpatient chief at ITC, will be hosting the Zoom session with Dr. Allison Goldberg, who will be joining us on an approach to code conversations. So I'll be sending out lots of information about that for you folks. Okay. Welcome everyone to our second ITC of the year. Gabby Berger, great to see you all again this morning. Any other questions or housekeeping things we should take care of before we get started this morning? Going once, going twice. Okay. All right. So if there are no questions, I'm going to go ahead and share my screen and get started in just a second. Last reminder, please do look at the chat. I'm usually really good at monitoring it while I am talking, but certainly possible that I may miss things. So feel free to unmute, tell me to pause, stop, and I'll take any questions that come up. Okay, so let me try sharing my screen. Okay, can somebody give me an emoji, thumbs up, or somehow in the chat, give me a thumbs up that you can see my presentation in?
We can see it.
You can see it, perfect. Okay, great. All right, trying to admit a few people. Okay, cool. Well, wonderful to see you all. And let's go ahead and get started. So our topic for today is being a super intern. So tips and tricks on cross cover. And the idea is that we know that you are all doing cross cover, often for the first time at the beginning of intern year. This is a new skill set for a lot of folks. And sometimes it can feel a little overwhelming. So the topics that we're going to be covering today are not always seem like the most exciting topics, but they're the ones that come up all the time. And they're the ones that we hope to give you just some really quick skills to be able to triage and manage folks so that you're not spending a ton of time doing this work when you really want to be admitting a patient or something like that. Okay, so let's get started. Okay, so here's our roadmap for this morning. Our plan is that we're going to talk about how to triage common cross-cover calls with a focus on practical skills for assessment and treatment. Okay, so the 4 topics we're going to cover, very exciting: altered mental status, nausea and vomiting, constipation, and insomnia. The things that you will get called about all the time. The one that often always comes up also is managing pain, inpatient pain. We have a whole talk coming up on that with Dr. Susan Merrill. That is too much usually to cover within this talk, so we carved it out as a separate talk. Okay, so I know some of you have already started on nights. You've already been doing cross cover. Let's just put ourselves in your shoes. It's 9 p.m. and the pager goes off. And it says something like this: "Doctor, your patient is altered." All right, so we're going to do a case-based presentation this morning. So we have a 65-year-old man, male patient with COPD, cirrhosis, and AFib who's admitted with a new pulmonary embolism. He started on a heparin drip, nebs, and oxycodone with morphine for breakthrough pain. And the RN pages you that they are holding the evening meds because the patient is somnolent. Okay, so being the fantastic intern you are, you check your sign out, you note that the patient is listed as a watcher, and you do a quick check of labs to see what their labs were during the day. Sodium was 127, BUN 75, and creatinine 2.1. All the other labs were normal. And here are the most recent vital signs. So you see that the blood pressure was 100/60, heart rate was in the 100s, the respiratory rate was 16, and the patient was satting 92% on 4 liters. Okay. So your exam just shows an irregular rhythm. You know that the patient has AFib, right? No lower extremity edema. Pulmonary exam, scattered wheezes, but no crackles. And on a neuro exam, the patient's somnolent. He does arouse to voice and withdraws from pain symmetrically, and there's no clonus on your exam. Okay, so here's our first question of the morning. So what's the best next step in evaluation of this patient? Are you going to give Narcan, 0.4 milligrams? Are you going to do a stat CTA of the head, stroke protocol? Are you going to order a stat Chem 7 and ABG, start 2% 2% saline at 30 cc's an hour, or give lactulose 30 grams Q4 hours? And here's our first poll. So go ahead and take a minute, maybe not a minute, maybe 20 seconds, enter the best next step. Great, keep those answers coming. All right. So I think we've got a critical mass here. So I'm going to go ahead and end the poll and share the results. Okay, so great. Many of you chose what I would consider to be the right answer here, which is stat Chem 7 and an ABG. But there are a smattering of other answers, and we'll go through this to explain why I think that choice C is the right answer. Okay, so let me move my poll out of the way here. So I'm curious, and you can feel free to put in the chat or unmute, who has an approach to altered mental status? And I see your note there, Ananya, and I would say pupils are not evaluated in this exam. Misto, love it. Misto, love it. Awesome. So maybe we've got some folks who have spent some time in my institution here at UW or prior institution. Misto is my favorite, but there are lots of others. And I think the most important thing is that you develop one approach to altered mental status, to thinking about evaluating altered mental status, come up with a framework that works for you and stick with it. And it really doesn't matter what that framework is, as long as it's reproducible for you and you can do it every time. Okay, so what is Misto? And I'll tell you why I like it. Other people like do Vindicates. I know in our med school, we still do Vindicates, not my favorite, super long. I can't remember that many things. So Misto is nice and short. Misto, metabolic or toxic causes of altered mental status. So this bucket really includes all of your electrolyte abnormalities and things like uremia, hepatic encephalopathy, medication effect, alcohol, drugs, etc., that kind of thing. So anything in that metabolic or toxic category. I is infectious. So infectious causes of altered mental status. S stands for both stroke and seizure. T stands for trauma. And O stands for oxygen, which I use to summarize both hypoxia and hypercarbia. Okay. So the reason I love Misto so much is, number one, it's easy to remember, but number two, it actually can help me drive a focused workup in the moment, a focused evaluation of a patient in the hospital, so that it makes me feel less sort of overwhelmed by this big topic of altered mental status. So even when I don't know a patient, if I use this framework, usually I can sort of home in on a workup pretty quickly. So when I'm thinking about metabolic causes of altered mental status, obviously going to get a Chem 7, check the calcium, and then you may decide, just sort of depending on the clinical scenario, other things you could check would be a Utox, serum and urine osms. Right. On exam, you want to look for asterixis. That's really going to help you with both hepatic and uremic encephalopathy. And then really critical is just reviewing the meds and the EMAR, or the electronic medical administration record, right? Just to make sure that what is prescribed is actually what's being given. Oh, I'm sorry. A Chem 7 is the same thing as a BMP, basic metabolic panel. sorry, different folks use different terms. So thank you for bringing that up. So infectious, if I'm worried about an infectious cause of altered mental status, things I'm going to do obviously is review the vital signs and think about an infectious workup. Remember that an infectious workup in the hospital usually involves blood cultures ×2, one off a line if there's a central line, one peripherally, and a UA with culture, as well as obviously you're going to do a CBC and a CMP, a complete metabolic panel. But that infectious workup is really the blood cultures, UA with urine culture. And you want to think about whether there are pockets of fluid other places that you need to sample. For example, is there ascites that could be infected? Is there a pleural effusion that could be infected as a pneumonic effusion? Okay. But the infectious workup is usually pretty focused. Okay. The thing that I want to help empower you to feel is that rarely in the hospital with altered mental status, acute altered mental status, rarely do you need to do an LP for an infectious cause, right? Because an LP is going to help you diagnose what from an infectious standpoint. Go ahead and throw something in the chat. What is an LP going to do? Help you diagnose what infection? Meningitis. Yes, thank you. Right. Just want to make sure you're all here with us this morning. Meningitis. And is it common for bacterial or even viral meningitis to present acutely in the hospital while you are on cross cover? No, it is not. So maybe when the patient is coming into the emergency room or is being initially evaluated for altered mental status, an LP is absolutely going to be indicated. But remember, we're talking about cross cover. And when you are called on cross cover for altered mental status, rarely do you need to do an LP to rule out meningitis. Okay. Next, stroke or seizure. If you're worried about having a patient having a stroke or a seizure, remember that all you really need to do is get a non-con head CT, right? Because a non-con head CT shows you blood. That's what it does. Shows you blood. So if you're worried about a hemorrhagic stroke or something, occupying the space, you are going to all you need is a non-con head CT. If you think there's a focal neuro deficit and you are truly worried about a stroke, then you need a CTA, a CT angiography of the brain. Okay. And you'll call neuro if you're really worried. Okay. If you're worried about trauma, and what do we mean by trauma? Usually in the hospital on cross cover for internal medicine residents, that means somebody fell out of bed, slipped and fell in their room, something like that. And so what you're really worried about is somebody's fallen and hit their head, and that's what's causing them to be altered. All you do is a non-con head CT, right? You're just looking for blood. And then finally, if you're worried about oxygen, so hypoxia or hypercarbia, that's when you're going to get that arterial blood gas, ABG, plus or minus a chest X-ray if you think that's indicated. All right. So using MISTO as a framework for altered mental status can be really helpful to in the moment to help you both think about a really clear, focused approach to an evaluation and quick assessment for evaluating or working up altered mental status. Okay, so we're going to go back to our case. I saw people wanted a Chem 7 or a basic metabolic panel and an ABG, so that's what you got. Your sodium, creatinine, and glucose are basically stable. ABG shows 7.2, 78, 74 on 4 liters nasal cannula. So remember, PCO2, 78, PaO2 is 74. I like that EEC. You see, you review the EMAR as we discussed, and you see that the patient received morphine 4 milligrams IV ×1 at 6 p.m. And so what do you think is the cause of this patient's altered mental status? In the chat, what are folks thinking? If you're just to go back to MISTO, hypercarbia, yeah, love it. Great, 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 great. Perfect. So absolutely. And all of you are saying sort of the same thing around hypercarbia, hypoventilation.
And
I'm going to ask folks to chat, to mute themselves, please.
What is do you know it? I thought I dialed it, but
I'm going to ask everybody to mute. See if I can mute you. Okay. All right. I think we're good. Okay, so being the excellent intern you are, you recognize that this patient is hypercarbia. Patient gets transferred to the MICU for non-invasive positive pressure ventilation, also known as BiPAP, and the patient's morphine is switched to hydromorphone. Okay, so any idea why the morphine was the thing that tipped this patient over? Yeah, all of these are great. Absolutely. And so just remember, one of the things that we're going to talk about in the session on pain, absolutely, this patient was tipped over. I'm sorry, the morphine causes respiratory depression, but it's really because the patient has CKD, right? So remember that morphine is cleared renally. So in patients with CKD, morphine can hang around a lot longer and is going to cause respiratory depression more easily or more quickly than you might anticipate. And so that's why we switched to hydromorphone in this case. Okay. All right. Awesome. Okay. So we're going to move on to another case of altered mental status. All right. So let's see. This patient was admitted. She's an 87-year-old female who's admitted for severe sepsis due to a UTI. She was treated with ceftriaxone. She got better, and now she's just awaiting sniff, skilled nursing facility. So now it's 9:15, and the nurse pages you asking for a sleeping pill. But being the great intern you are, you decide you better call and figure out what's going on, and you find out that the patient seems off. So you get some vitals and they are all very normal. But when you go see her, you notice she's picking at her blankets, trying to sit up. She thinks she's at home and she's yelling at someone to get off the ceiling. Okay. So what's going on for this patient? Delirium, absolutely. Yes, this is not meant to be a mystery. This patient is delirious. Okay, so I want to spend just a couple minutes talking about delirium in the hospital because it is so outrageously common in the patients you'll see. And I share this study just to remind us how many patients you will see in the hospital who develop delirium at some point, unbelievably high in the MICU when folks are mechanically ventilated. So thinking about ways to manage delirium, remember that some of the most important things are just managing patients' pain, urinary retention, and constipation, especially in older folks or in folks who are medically frail, is an unbelievable trigger for delirium in and of itself. You want to try to avoid opioids and other sedating medications if possible. Of course, this makes it difficult when you're trying to manage pain. So again, we're going to talk about some strategies in more detail during our pain session later this summer. And then the most important thing is you really want to prevent some complications of delirium, like falling out of bed. There is this glorious thing called the Delirium Power Plan that is available in your Epic workflows on the inpatient side at Harborview and at UW. And really what this order set does is empower the nurses to do a whole bunch of things on their own so that they're not paging you every 5 minutes to help manage delirium. So things like placing a commode at bedside, getting a safety mat in place, removing tubes, lines, or strains, that kind of thing. So a lot of this is very nursing driven, and you want to empower your nurses to do this on their own. There are, of course, times when you may need some medications. And so I want you to remember two. When you are managing delirium in the hospital, you have two options. The first is haloperidol or Haldol, and the second is quetiapine or Seroquel. These are the two that tend to be most helpful in the acute setting if you're managing delirium, where somebody is really putting themselves at risk or others. Okay, haloperidol can be given usually as a 0.5 to 1 milligram dose. And note that this is the only one that's available IV. So if you are having difficulty getting a patient to take something PO, haloperidol or Haldol is really your only option in the acute setting for delirium. Whereas Seroquel can be really helpful if the patient can take oral medications. Remember that you want to start low and go slow, which is why you start with these lower doses. You do want to check the QTC on an EKG if you have time to do so before giving these medications. It's not always possible. And at the low dose, it's usually fine, but you do want to remember to check if you can. And remember, I often get this question about, is there an increased risk, or what about the increased risk of mortality in patients with dementia when using these medications? And that's absolutely something to consider. The thing to remember is that data really comes from patients who are on these medications chronically, not for using them on a PRN basis acutely in the hospital. Okay. So back to our case for this patient with delirium who was awaiting skilled nursing facility. She was on oxycodone 5 to 10 milligrams Q6 hours PRN, which is super common in the hospital. You note that she's had very low urine output. And so you order an INO, in and out, or a straight cath, which drains a liter of clear urine. She was retaining urine because of those opioids. She feels so much better and promptly goes to sleep. And of course, you are a super intern. All right. So before we go to our quick take, well, actually, maybe I'll do the quick take. Let me just take a quick look at the chat, see if I'm missing anything here. All right, I think we're good. But please feel free to throw questions down in the chat. We're going to do quick take on altered mental status. So now you have a 78-year-old man with metastatic lung cancer who's been admitted for pain. You're called for a new onset seizure. And the details are that 5 minutes ago, he had a witnessed generalized tonic-clonic seizure that lasted 60 seconds while the nurse was administering the medications. And now the patient's unresponsive. His O2 sats initially dropped into the 70s, but now he's in the low 90s on 2 liters nasal cannula. So my next poll question for you folks is, what is the best next step for this patient? Are you going to give lorazepam, 2 milligrams IV now, phenytoin load, levetiracetam, also known as Keppra? Are you going to observe and order a brain MRI with contrast, or do a stat ABG? Give everybody about 30 seconds to answer this question. All right, remember, nobody sees your answers. Commit to an answer choice. It's the best way that we learn. Okay. Oh, excuse me. Where's my cursor? There we go. All right. Looks like we've reached a critical mass. This is awesome. I'm going to share the results. Folks are all over the board. And that is exactly why we do this question, because I think it's really important. Let me check the chat here. I will absolutely go back to the vignette for folks when we're doing the question. The right answer in this case actually is observe and order an MRI brain with contrast. And so we're going to talk about why that is here. First, I want you to just note now the patient, you've gone to evaluate the patient. The patient is post-ictal, is protecting his airway, but he's awaiting MRI. And now the nurse pages you that he's having another seizure. Okay. So now I'm going to ask you the same question again. Okay, let's stop sharing. I'm going to ask you the same question again. So now we've got a second seizure. What are you going to do now? So patient who has metastatic cancer, he was admitted for pain, had a new seizure, and initially we're going to do an MRI brain with contrast, and now he's having a second seizure. Great. Okay. Getting the last few answers here. Okay. So now we've got the vast majority of folks selecting lorazepam 2 milligrams IV times 1, which I agree is the right answer in this case. So why is that? Let's talk just very briefly about acute seizure management in the hospital. So number one, for seizures that are less than 1 to 2 minutes and break spontaneously, we can just observe. So for that first vignette, when you're being called, the patient has already had the seizure is over. You do not need to give medications in that moment because the seizure is over. It was the first witness seizure. Okay. In that case, we're actually going to do a brain MRI to try and figure out why he's having a seizure. He has metastatic cancer. And so presumably he has new mets in the brain. And that I'd want to know so that you can then treat potentially with dexamethasone or something else if there is a mass effect. But for the seizure, no meds for that first seizure that breaks spontaneously. For a seizure that lasts for more than 1 to 2 minutes, or it's a recurrent seizure. So now he had a second seizure. Now you're going to give lorazepam or Ativan 2 milligrams IV times 1. And for ongoing seizures in the hospital, really you have two choices. And I've talked with our neuro colleagues. You can really either give a phenytoin load or levetiracetam, which is Keppra, and both are very reasonable. Okay, great. All right, so altered mental status, this is our sort of longest, biggest topic of the morning. Take home points from the things we just discussed. When you're thinking about altered mental status, please, please, please use a framework. I like Misto for the reasons I described to organize the differential and drive your workup and evaluation of that patient. If you have another one that works well for you, another framework, that's great. Just use the same thing every time so you don't miss things. Number two, think about treating delirium with environmental modifications like we discussed, using medications as a last resort, but they are there if you need them. And remember, your inpatient options are haloperidol or quetiapine. And then finally, use lorazepam for active seizure, and then a phenytoin load or levetiracetam for recurrent seizures. So usually, Marcus, that's a great question. Do you give phenytoin and levetiracetam? Are you still giving lorazepam? Usually you've already given lorazepam, the seizure is not breaking or it has broken, and then you're giving those other longer acting medications sort of after you've already given lorazepam. Great. And if that patient is really having seizures that aren't breaking, I should say you're going to call neuro in that moment also, but right, you're going to be the first call. You can give a lot of lorazepam. So if the patient has a seizure, you give lorazepam, the seizure breaks, the patient has another seizure, you give lorazepam again. If you're getting a lot of respiratory depression because of the lorazepam, you call your MICU colleagues or even anesthesia to make sure that the patient is getting transferred to the right part of the hospital. Great questions. Okay. We don't give a lot of phenobarb as the first. Remember, this is management of the acute seizure in the moment. The first, like you're getting called as cross cover. We're not going to use a lot of phenobarb in that situation. For recurrent seizures, seizure disorder patients, you may consult neuro. That might be part of a complex seizure management. But again, what we're trying to focus on this morning is things that you're going to do on cross cover. So great question, Joey. Thank you for that. All right. So let's move on to our next topic. Doctor, your patient is constipated, a very exciting topic for everybody I know. Okay. So now you've got a 66-year-old patient, a male patient admitted with cellulitis, lower extremity cellulitis and volume overload. It's hospital day 4 for this patient, and you get paged at 11 p.m. for mild abdominal discomfort. The patient has not had a bowel movement since admission, and you are down in the ED admitting another patient. So what are you going to do next for this patient when you get called? Are you going to prescribe Docusate? Are you going to prescribe bisacodyl suppository? Are you going to do Senna, tap water enema, or get more information from the nurse? Are you going to call and get more information? And here's the vignette. Okay. Lots of answers coming in. Love it. Okay, friends. I'm going to end this poll. And I just want you to know that I'm about to blow your minds. You can see that all of you are really super interns, you're super conscientious, and you all want to call the nurse and get more information. Okay, so I am going to move forward. So in this case, why do I think getting more information is not the right answer? I'm going to tell you why. In this case, I think you could go ahead and give bisacodyl, which is also is a rectal suppository, or do a tap water enema for this patient. So what am I trying to get at here? Really, you are all busy doctors, right? You are getting a lot of cross-cover calls. You are trying to do a number of things at once. So I want you to think about what's the minimum amount of information you need by phone to evaluate constipation in the hospital. And I don't know if any of you have had this experience yet, but I wonder if on nights, your last night looked anything like this, which is certainly nights that I've had in the hospital, or even just days in the hospital or on cross cover. There's a lot of things going on, and I want to help you think about how to triage. Okay, so when you're thinking about constipation in the hospital, ask yourself this question: is this a symptom of a more serious condition? For example, does the patient have a new fever? Are there new vital sign changes? Does the patient have risk factors for obstruction? Right? Is there a risk factor for something else, something bad going on? And if not, right, this patient was in the hospital for 4 days for cellulitis and he just hasn't pooped, it's usually okay to treat empirically. And the question then you have to ask yourself is, do you want to start from above or start from below? Okay. So really, what's your goal in treating constipation? Do you want the patient to have a bowel movement now? Do you want the patient to have a bowel movement by the morning, or sometime, like in the future when you're not seeing that patient in the hospital anymore? And that's really going to drive your choices, your treatment choices for constipation. So things that I want you to think about are what we use to treat constipation can either be categorized as slow acting, moderate acting, or fast acting. Okay. Things that are slow acting are like Metamucil or stool softeners like Docusate, which I'm sure you all know the data that shows that Docusate is really no better than placebo. These are medications that I never prescribe in the hospital, because if a patient is coming in and the patient is complaining of constipation in the hospital, they usually don't want to wait days to have a bowel movement. They want to have a bowel movement now or very soon. Right? If a patient is on Docusate at home and they're really attached to it, sure, you can put that back on their med list, but it's very unlikely to have any effect anytime soon. So things that act moderately quickly, like within the next 24 hours, can be very effective in the hospital. So various formulations of polyethylene glycol, which are Miralax, Go Lightly, things like Laxulose, these are osmotic agents that move the stool more quickly through the colon. Okay. Other things that act moderately quickly are Senna and bisacodyl, which can be given orally. And that's a stimulant medication, and so helps move things through the colon more quickly. Then, of course, there are things that act really fast, right? So things within minutes to hours, usually that's an enema or a rectal suppository, or moving from above, magnesium citrate, mag citrate, is a saline laxative that patients can drink. And man, does it work quickly. Okay. So in the hospital, I am almost always going for this category of situation for patients who are constipated. Okay. Awesome. Okay. Questions about that before I move on to an advanced case of constipation? I know it sounds simple, but I just really want you folks to feel like you know what these medications are, you know how quickly they act, and most of the time you don't need to go do a whole evaluation of a patient to decide if you're going to give them some Miralax or write for a suppository. That is something you can do without evaluation. Okay, but there may be cases when constipation is more serious. So now we've got a 38-year-old man, male patient with sickle cell disease who's admitted for a vaso-occlusive crisis. He's using a PCA, so patient-controlled analgesia, giving himself quite a bit of hydromorphone. And he is on scheduled Senna and bisacodyl to try and prevent constipation. On hospital day 6, he now has new abdominal discomfort and constipation, no improvement with a bisacodyl suppository or a tap water enema. So because this is a little bit more complicated, being the great intern that you are, you decide, gosh, maybe this patient does need an evaluation. He's already done the things that we do typically in the hospital, and they're not working. So you get an abdominal X-ray or a KUB after you evaluate his belly, and this is what you see. Feel free to put something in the chat if you have an idea of what this might be. Full of gas. Yep, totally. So I'm going to say that this is actually unlikely to be an SBO. Thank goodness, but you're absolutely thinking about the right thing for people who put that in the chat. That's the thing you want to rule out, right? Fortunately, we don't see a lot of air fluid levels, so we do think this is likely an ileus, right? So lots of gas, things not moving, but no air fluid levels, more likely to be an ileus. Great. So now what's the next best step for this patient? Okay. And let me put up our poll here. So is the next best step methyl naltrexone, naloxone, place an NG tube to give go lightly through an NG tube drip or gastrographin enema. And I'm not going to go all the way back to the vignette for this patient, but I'll just remind you, 38-year-old gentleman with sickle cell disease on a PCA, so getting a lot of opioids with an ileus. Great. Lots of great answers coming in. Give you just another second with this. Awesome. Okay. So I'm going to go ahead and end the poll here and share the results. So again, in this case, folks sort of all over the place a little bit. So some folks going with methyl naltrexone, some with the go lightly drip, and some with gastrographin enema. So in this case, I'm going to argue that the correct answer is methyl naltrexone. And let's talk about these different options and why. Okay, so let me stop sharing that poll. Excuse me. Okay, so options for what are we really talking about here? Options for bad constipation that are sort of less common causes. And so things that you just need to think about or be aware of in the hospital. So methyl naltrexone is a medication that acts to reverse the effects of opioids specifically in the gut. So it does not cross the blood-brain barrier, will not induce withdrawal. Okay, this is really important, and it can be very helpful for opioid-induced ileus in the hospital. So we often see patients on very high dose opioids. For example, patients with cancer or sickle cell disease who are on those PCAs, methyl naltrexone can be very effective at promoting a bowel movement in those cases. Polyethylene glycol, the go lightly drip given through an NG tube, is actually something that we do for our patients. The most common indication is patients with CF, so cystic fibrosis. We're a very large CF center at the University of Washington, usually at the Montlake or even the Northwest campus. You folks won't rotate up there. But remember that these adults with CF get a lot of inspissated stool in their small bowel, and it's called DIOS or distal intestinal obstructive syndrome. And when you have that inspissated stool, that's when we put the NG tube down and just drip, go lightly, slowly, slowly, slowly at a constant rate into the small bowel, and it helps dissolve and move that stool through the intestinal tract. The gastrographin enema is something that's given from below. It is an enema, and it's good in the case of impaction. So remember that it can cause electrolyte shifts, so you might want to be careful with somebody who has bad CKD, but honestly, not usually an issue, and it's usually pretty safe. Okay. All right. So take home points on the topic of constipation. So I think number one, I always love every year that all interns want to evaluate every patient with constipation. I don't think you need to do that. You don't need to go to the bedside, but you do want to think about cases in which you should go to the bedside to evaluate constipation when it's a more complicated situation, and try choosing your therapy based on how quickly you want results. Okay. Any last questions about constipation before we move on? Okay. Next topic is nausea. So doctor, your patient is nauseated. Happens all the time. So when would an NG tube not be in, when would an NG tube be indicated? Are you talking about for nausea, Dan, or for something, or for constipation? For constipation. We almost never do an NG tube, except unless you're putting in an NG tube specifically to drip, go lightly. SBO is different. That is not constipation. SBO is not constipation. SBO is a small bowel obstruction. And that is a different topic. And that is a different management. And that requires an NG tube. But SBO is not, just to be really clear, is not constipation. Ileus is constipation. So that's a great question. And differentiating that is important. All right. So it's all good, Dan. That's absolutely why we're here. Okay, so you have a patient who's nauseated, 51-year-old male patient with pancreatitis, admitted 3 days ago to the MICU, and the patient was treated with IV fluids and bowel rest, transferred to the floor today. The patient is still NPO. The vital signs are stable, but he is nauseated. So the patient, you get called, and the question is, what do you do next? Are you going to evaluate the patient? Are you going to prescribe ondansetron, 8 milligrams PO, and finish I should have told you, you're in the ED doing an admission. I think I said that. So you're going to finish that ED admission. Are you going to give ondansetron 8 mg IV Q8? Are you going to give lorazepam or find a bathroom and hide your just over all these pages? Good. Keep the answers rolling. I like it. Okay. I'm going to go ahead and end the poll here. And again, a bit of a smattering of answers here. But I like that you all are getting my theme here, which is that you don't always have to evaluate the patient. And the question is, as an intern and developing some of these cross-cover skills, is really trying to decide when you need to triage and go to the bedside and when you don't necessarily need to do that. I want to say it is always okay to go to the bedside. So if you want to go to the bedside and evaluate this patient, that is totally okay. I just want to give you some other tools as well. And in this case, I think that you can give ondansetron or Zofran 8 milligrams IV Q8. All right. So let's talk about the emesis ladder, or really the anti-nausea ladder. So medications that you can use for nausea and when you should use them in which order. So almost always we start with ondansetron, 8 milligrams IV Q8. If that is not working, we will move up to metoclopramide, which is also called Reglan, IV Q6. If that is not working, the next one we go to is often prochlorperazine or compazine, 5 to 10 milligrams IV Q6. And then finally, promethazine. Let's see, there we go. Promethazine, which can be given at a very low starting dose of 6.25. And that can be given either PO or PR, meaning per rectum, Q6. Okay, so what I want you to notice is for inpatients, almost all of these medications are IV. You can start with PO if you want, but you will almost inevitably get paged that this nauseated patient does not want to take more PO meds, and or the PO meds aren't working. So for a nauseated patient in the hospital, it is okay to go right to IV. The exception to that is promethazine or Phenergan, where I strongly recommend giving either oral or rectal if you even have to go there. But that should be your medication of last resort. Okay. The reason that we go in this order is because there's an increasing risk of side effects the further up the ladder that you go. Okay, so let's think just very quickly about side effects. Remember that with ondansetron or Zofran, super safe medication does have some QTC prolongation, so that's something to be aware of. Metoclopramide and prochlorperazine, so Reglan and Compazine, are both antidopaminergic and can cause dystonic reactions, but this is very rare. I've only seen it a couple times in the hospital. And then finally, diphenhydramine, which is Benadryl, and you notice was not even on the ladder, as well as promethazine, which is those are both antihistamines, and they cause a sedating effect. They can cause people to have a high, to feel a high, which is why we try at all costs to avoid giving them as an IV. You will see situations in which you do give them IV, but I would say as a general principle for treating nausea, if a patient is asking you for Phenergan or Benadryl IV, that should be a red flag, and you should be talking to somebody about that, like your senior or an attending. Okay. All right. So I want to do quickly and one other case related to nausea. So now we have an 84-year-old female who's admitted for community-acquired pneumonia. She has a past medical history of hypertension, hyperlipidemia, diabetes, and a stroke. Overnight, she develops new onset nausea and vomiting. Her vitals are BP of 90/54, heart rate of 108, and she's satting 95% on room air. She's oriented, but she's complaining of epigastric discomfort. So now if you contrast this with the last patient we talked about, who was a patient who had pancreatitis, stabilized in the ICU, and is now coming out totally stable, that patient has a good reason to be nauseated, right? Like he has pancreatitis, not feeling good, probably okay to treat with IV ondansetron and and evaluate if he's not getting better. This patient feels like maybe something else is going on. Vitals don't look great. She has epigastric discomfort when she was admitted for community-acquired pneumonia. That seems odd. So you decide to evaluate her. You notice that she's tired, appearing, and mildly diaphoretic, and her vitals do not look great. So being the wonderful intern you are, you decide maybe you get an EKG in this case, and you see some stuff that looks a little scary. So I'm going to let you all look at that for just a quick second. Okay.
I don't see.
All right. So the question about nausea is really, when do you want to evaluate in person? So 3 scenarios. If you are worried that this could be an atypical presentation of an MI, like this patient in the hospital has really significant coronary artery risk factors, or has other unstable vital signs that would make you think, gosh, is there something else going on? Then you would want to evaluate that patient in person at the bedside. If the patient has new mental status changes with headache, with their nausea, you might be worried that there's something going on intracranially, and you want to evaluate that patient at bedside. And then finally, if there's any coffee ground emesis, hematemesis, abdominal pain associated with that nausea, that might be somebody you want to evaluate at bedside. Okay, so I want to help frame that sometimes you absolutely want to go to the bedside for nausea, but you don't have to do it all the time. And I want you to sort of have a framework for thinking about, when do I need to go evaluate this person? And when is it okay to prescribe a medication just sort of in epic after getting paged? Okay. So going back to that last case, you call your senior, you activate the STEMI pager because you notice the ST elevations on that EKG. The patient goes for emergent PCI. Everyone thinks that you're the best intern ever, because of course you are. This is Mia Mayhem. She's one of my kids' very favorite superheroes these days. And so take home points for nausea. You don't need to do a bedside evaluation for every patient. However, consider the possibility of a more serious illness like an MI, CNS disease, or a GI bleed. And then avoid Benadryl and Phenergan. Those are not great nausea. They can help with nausea, but they also make people feel real good in ways that we are not intending to in the hospital. All right. And we are rounding out the hour here, folks. we're going to do a quick take on our very last topic this morning. Doctor, your patient can't sleep. All right, the last poll question I'm going to ask you today. So it's now 2 a.m. You're getting your 67th page of the night. And let me get my poll question ready for you. This is a patient who is a 49-year-old male with lower extremity cellulitis. He has anxiety and depression, and he is requesting his home zolpidem or Ambien 10 milligrams QHS. So at night. So what do you do next for this patient? And I'll go back to the question stem. Do you order trazodone 25 milligrams, order diphenhydramine, which is Benadryl 25 milligrams, temazepam 15 milligrams, zolpidem 10, or evaluate the patient? All right, love those answers coming in. Okay. All right, so I'm going to go ahead and end the poll and share the results. And so most people said either trazodone or zolpidem. And I think that's exactly right in this case. I think that either of these answers are correct. And the important thing here is to remember that there's almost always in medicine more than one right way to do things. Okay, so this would not be a board question. This would be a bad board question because there are two right answers. But that's okay, right? There's more than one right way to do things. So when you're thinking about an approach to insomnia in the hospital, right? Things that we want to consider are environmental factors. You all know about keeping the lights off, treating people's pain. But one thing to remember that we often forget about is stop checking vital signs overnight. Our typical vital signs on the floor are Q8 hours actually, which is not that frequently. But if they're timed such that the patient's getting woken up at 2 a.m. for vitals, that's a terrible time to get vitals for most patients when they're sleeping, unless they really need it. So retime the vitals so that they're at 10 p.m. and 6 a.m. You're still getting your Q8 hours, but then the patient actually gets to sleep. Also rescheduling meds so that they're not getting a medication at 2 o'clock in the morning that could be given earlier in the evening. Oftentimes we sign out INO checks and then like giving another dose of diuretic. Just remember that when you're giving a patient like a dose of Lasix or Bumax or torsemide or whatever it is at 11 p.m., they're going to be peeing at 2 or 3 o'clock in the morning, right? And so you're then going to get paged because that patient is peeing at 3 o'clock in the morning. So to the extent that you can, it's not always possible, but try retiming those meds for a little bit earlier in the evening. When you're thinking about insomnia, remember to ask yourself, is there a concern for delirium? Because if there's delirium involved in this insomnia, then we need to go back to our first topic of altered mental status and think about further assessment and workup of the delirium. Okay. And then the last question, or maybe sometimes the first question I ask myself, is this a chronic problem? If this is a chronic problem for a patient, it is okay to order their home medication. So treating insomnia in the hospital, everybody knows about melatonin. It can actually be pretty helpful. It's not always going to work, but it can be a good place to start for folks. In the hospital, we'll often give trazodone, 25 to 50 milligrams at night. Remember, at a very high dose, like 200 milligrams or more, it's an old antidepressant, but at low doses, it can be very effective for sleep. And it's really good for short-term use only. It's not something that we would want to necessarily do long-term in the clinic, but as a short-term med in the hospital, it usually works quite well. Remembering, I know most folks know this, but we really want to avoid benzodiazepines and diphenhydramine, which is Benadryl, especially in elderly folks, especially in the hospital, very delirium inducing. So we would really reach for things like trazodone instead. So very brief take home points for insomnia. Trazodone 25 to 50 milligrams is your friend. It's okay to use that in the hospital. I would say avoiding zolpidem, which is Ambien, in the hospital, unless the patient takes it at home. And if the patient takes it at home, it is okay usually to prescribe that in the hospital. And then trying to do things like rescheduling medications and vital signs during the day. And that can be really helpful. Okay. So we are at the top of the hour, my friends. So hopefully we covered 4 topics in a sort of range of detail in terms of cross-cover tips and tricks for today. So my conclusions are, number 1, of course, you are all super interns. Use a framework for altered mental status. It will help you each and every time. It still helps me when I'm attending in the hospital. Constipation can often be triaged over the phone. Sometimes you need to go to the bedside, but it is okay to try and do that over the phone once you feel comfortable. Consider risk factors for a myocardial infarction or GI bleed when assessing for nausea. If you don't think those risk factors are present, it's also usually okay to triage that over the phone. And then melatonin or trazodone for sleep. Those are usually your friends. All right. So I'm going to stop sharing here. I'm going to stay online and see what questions folks have. I'm going to put 2 links in the chat, please, both an attendance link and a quick evaluation link. And if you can take 2 seconds to do attendance and evaluation, I would greatly appreciate that. I'm happy to take any questions. There are no questions. Amazing. Not seeing the links in the chat. Oops, I'm sorry. I sent them directly to Joey. That's not helpful. I'm so sorry, everybody. I'm sorry, Joey. There we go. I apologize. Thank you for staying on for 2 seconds to get that done. I appreciate it. Quick reminder that next week we will have Molly Kelly hosting ITC for you all. And I'll be back with you in 2 weeks. As always, don't hesitate to send me questions, email, text, anything like that. And I will post the recording as well as